Hi, are you ready to learn about the next chapter in the ICD-10-CM chapter specific guidelines? Don't worry, I got you covered. This is Surya Johnson, your medical coding guide. Hi, in today's video, we're going to see the next chapter in ICD-10-CM chapter specific coding guidelines. In the last video, we covered the first chapter in the chapter specific coding guidelines, which is the certain infectious and parasitic diseases. Series starts from A00 to B99, also includes U07.1 and U09.9. We covered the first chapter in two different videos because it's a big chapter to be covered. So I did it in my two previous videos. If you have not seen that yet, I'll put the links in the description below, so you can go first watch those chapters and then come to this chapter specific guidelines, the number 2, Neoplasm. Let's dive in. So in today's video, we're going to see about the chapter 2 under the C section of chapter specific guidelines, which is Neoplasms. The series starts from C00 to D49. Why do I emphasize on the series? Because if you know which series contains which type of conditions or disease or symptoms, it will be very much useful for you while doing the examinations. Like if you find any questions and you saw some options, if you already know the series, like for example, if you know that Neoplasm series is always from C00 to D49, you can easily rule out the other options which does not have this series. So always, remember, or if you can memorize the series, which will be very beneficial to you during the exam and also in your work. Learn your series in the ICD-10-CM, and also you should know the series, number series in your CPT code books. So in this series, in the Neoplasm chapter, it contains most of the benign neoplasm conditions. The C2D49 series contains most of the benign neoplasms. Few benign neoplasms are found in specific body system chapters. In the different body system ICD-10 chapters are there, right? It is covered in there. And this chapter contains all malignant neoplasms. Also, if it's malignant neoplasm, if there are any secondary site that is metastated to from the primary site to secondary site, if the cancer has been metastated from the primary site to the secondary sites, it should also be determined and coded. So the first thing in the neoplasm is, first you should know what is benign, what is in situ, what is malignant, what is the uncertain behavior of the neoplasm. First you should understand these things, then only it will be very much easy for you to determine the neoplasm from the documentation or the patient record. So what is benign? Benign is an abnormal but non-cancerous collection of cells. So benign means it is not cancerous, but it is indeed an abnormal thing. It can be a mild lump or any swelling in the body. So it is called as benign. So in situ means a group of abnormal cells that are found only in the place where they first form in the body. It didn't mitigate, or it didn't grow out of that place. It didn't go to various different body parts. You can say, like in some patients, there will be a group of cells that is an abnormal growth or a lump or swelling, something like that, which is formed in one place, which is there for so long. It is not moving, or it is not spreading, or it is not growing. In this case, it is called as in situ. The next one is the malignant. So malignant means a cancerous tumor. It develops when abnormal cells grow, multiply and spread to other parts of your body. So this malignant means it's like cancer. It's a cancerous tumor. So it develops and it grows, and also it sometimes spreads to other parts of your body, and obviously that is the cancer. So when the doctor states the patient has a malignant neoplasm, it means the patient has cancer. If the doctor says it's benign or in situ, it is non-cancerous. In situ in the beginning might look like non-cancerous, but some in situ abnormal cells, if they move around the body, if they spread and develop in other parts of the body, if it develops to a cancerous tumor, then it becomes a malignant. The next one is the uncertain behavior. which means the lesion is currently benign but could become a malignant over time. So, the doctor couldn't predict whether it is a non-cancerous abnormal cell. It looks like it might become a malignant over time. In this scenario, the doctor will not predict that as benign neoplasm, because if it's benign, it becomes a non-cancerous one and the treatment or the severity or the patient's care will be reduced. But if it's documented as uncertain behavior, it is neither cancerous nor non-cancerous, but the high chance of becoming malignant over the time is there. So, in that case, the patient will receive all the care that is required to eradicate that abnormal growth. So, in this scenario, the doctor might state that it is an uncertain behavior. So, why do I want you all to know about what is malignant, what is in situ, what is benign and what is uncertain behavior? Because the neoplasm table that is available as a part of the alphabetic index, it is segregated or it is divided in based on these terms only. So, when the doctor is giving a neoplasm of a site or whatever it is, based on the documentation, you should first find out whether that it is a benign neoplasm or a malignant one, or is an uncertain behavior or cancer in situ. So, based on that, you can choose different codes for the same site. The code series or the code set differs. So, you should know what is malignant, what is in situ, what is benign and what is uncertain behavior. So, in this table you can also find another one like unspecified behavior. So, what is unspecified behavior? Doctor didn't mention what kind of neoplasm it is. It is a benign or a malignant or whatever it is, even uncertain. The doctor didn't conclude or didn't document. In this scenario, first you should always query the physician, and even after querying the physician, if it is not clear, then you should go for the unspecified behavior. In some scenarios, the histological terms will be different, like you cannot find out whether it is benign or malignant or uncertain behavior or whatever it is. These histological terms, so histology means this tissue has been sampled, biopsied, sampled and is been processed in the lab, and then the microscopic structure of the tissues are studied. After that, they derive what kind of neoplasm it is. Sometimes it will be in these terms, for example, adenoma. So, if you find these terms, you cannot understand whether it is benign or malignant or whatever it is. So, in this scenario, what you should do, you should not decide by yourself. You should always get into the alphabetic index to diseases and injuries. Like for example, if you go and search for adenoma, in the bracket it will show see also neoplasm benign by site. So, if this adenoma, whichever organ it is, you should go to the neoplasm table. So, it states that adenoma is a benign. So, you will go to the benign section and you will go and search as per this site. So, based on that, you will choose the code. Under neoplasm, the A, admission or encounter for treatment of primary site. This is a revised text, it is in italics, right? So, it is a revision for 2023. So, if the treatment is directed at the malignancy, like with the site of the neoplasm, then you should designate the malignancy as the principal diagnosis. Whatever treatment they go for, then if it is for that malignancy, then you should assign the malignancy as the principal diagnosis. But there is an exemption. What is an exemption? If that treatment is for the admission or encounter is solely for the administration of chemotherapy, immunotherapy or external beam radiation therapy, in that scenario you will not code the malignancy as a principal diagnosis. You will go for the Z51 series as the principal diagnosis, followed by the diagnosis of the problem for which the service is being performed as a secondary diagnosis. So, the neoplasm, in this case the malignancy, in this case will be the secondary diagnosis if the treatment is for administration of chemotherapy, immunotherapy or external beam radiation therapy. Next, B is admission or encounter for treatment of secondary site. This is also a revision text, it is in italics. If the patient is already having a primary neoplasm and it has been metastated and spread to a secondary site. So, the patient has a primary neoplasm and also a secondary neoplasm. So, in this scenario B, if the treatment is directed or the patient is going to the facility for treating the secondary neoplasm site, then where the treatment is being directed, that you should code as the principal diagnosis. So, the secondary neoplasm will be your principal diagnosis and your primary neoplasm will be your secondary diagnosis. So, listen carefully, your secondary neoplasm should be your principal diagnosis. It does not mean your secondary neoplasm will be changed to primary neoplasm. No, sometimes if there is a primary neoplasm of the lung and there is a secondary neoplasm of we can say like stomach. So, if the patient is going for the treatment of the secondary neoplasm of the stomach, you should not code that stomach neoplasm as primary neoplasm. Got my point, right? Because so many people they get confused by this exactly in the exam time. So, you will just still code the stomach as a secondary neoplasm, but you will place that position as a principal diagnosis, and your lung, which is the primary neoplasm in this scenario, you will code as primary neoplasm only, but it will be in the secondary place, secondary diagnosis. You got my point, right? So, do not confuse the primary and secondary with the principal and secondary diagnosis. So, it is vice versa. If the treatment is for the primary neoplasm, you will code the primary neoplasm as a principal diagnosis and your secondary neoplasm will be the secondary diagnosis. So, the next scenario, C, coding and sequencing of complication. Under that, the first one, anemia associated with malignancy. So, the patient has a malignancy and then the patient has developed an anemia because of this malignancy. Because of this neoplasm or malignancy, the patient develops later the stage anemia, and now the treatment is going for the anemia. So, you will all have the urge to code anemia as the principal diagnosis, right? No, this is the only scenario where it differs. In this scenario, you will still code the malignancy or as a principal diagnosis, and D63.0, which is anemia in neoplastic disease, will be your secondary diagnosis. So, do not confuse in this point. So, even if the treatment is directed for the anemia, but the malignancy will be the principal diagnosis. So, in the next scenario under the coding and sequencing of complication C, this too is anemia associated with chemotherapy, immunotherapy and radiation therapy. So, in this scenario the patient has a neoplasm and then the patient is undergoing for chemotherapy, immunotherapy and radiation therapy. Later, because of these therapy, not all three therapies, any one of the therapies or any couple of the therapies, because of these therapies the patient develops anemia. So, in this scenario you will code anemia as the principal diagnosis, secondary will be your neoplasm, and then the tertiary diagnosis will be adverse effect of anti-neoplastic and immunosuppressive drugs, that is T45.1x5, and also Y84.2, which is the radiological procedure and radiotherapy as a cause of abnormal reaction of the patient or a later complication without mention of misadventure at the time of procedure. So, this tertiary diagnosis you will be adding to show that there is an adverse effect of that anti-neoplastic and immunosuppressive drugs that has resulted in the anemia. So, this is how you will code. So, if the anemia we saw in number 1, I will repeat it again. So, we will all have a clear picture. The first, anemia associated with malignancy. If the anemia is because of the malignancy and the treatment is directed towards anemia at that visit, you will still code the malignancy as a principal diagnosis, and D63.0, which is anemia in neoplastic disease, will be coded secondary. But the second point, if the anemia is not because of the neoplasm, the anemia is because of the treatment, that is a chemotherapy, immunotherapy or radiation therapy. Because of that the patient developed anemia. And now the anemia is being treated, then you should give the principal diagnosis as anemia, the secondary diagnosis as neoplasm, and your tertiary diagnosis will be these two. So, this anemia due to the malignancy is only the different scenario. So, do not follow the same scenario for everything, only that is the different kind of scenario. So, you should remember that one. It is easy to remember also because everything follows the same rule, only this one, because there is a logic behind that. So, do not get in deep into that all those things. So, just learn like this. So, the next one under C, coding and sequencing of complications, is the management of dehydration due to the malignancy. So, the patient has a neoplasm malignancy and the patient has developed dehydration, that is loss of hydration in the body. The patient is dehydrated. So, the treatment for the patient at that visit is for treating the dehydration. Maybe the patient is coming for intravenous rehydration. The treatment is directed for the dehydration. The principal diagnosis should be Dehydration, obviously. Now you understood, right? So, the malignancy will be the secondary diagnosis. So, the fourth one under coding and sequencing of complications, treatment of a complication resulting from a surgical procedure. If the patient has been admitted and there is a treatment, the admission is for the treatment of the complication which is resulted from a surgical procedure. In this scenario, you will code that complication as the principal diagnosis. So, that is all under the C, coding and sequencing of complication. The next one, D, primary malignancy previously excised. So, excised or eradicated, it means there is no further treatment, no evidence of any existing primary malignancy. It means the patient's, the malignancy has been excised, excised means surgical removal, or eradicated, eradicated means completely resolved, completely it's been resolved. So, and there is no further treatment required for that primary malignancy, and there is no evidence of that existing malignancy in the patient's body. So, it means it is completely excised or eradicated. In this scenario, you will code the principal diagnosis as personal history of malignant neoplasm, Z85 series. Personal history of malignant neoplasm. So, what does it mean? It means the patient had a history of malignant neoplasm, and right now the patient does not have that malignant neoplasm. So, it becomes a patient's personal history, Z85 series. So, if there is any mention of extension, invasion or metastasis to another site, that means that primary malignancy is eradicated, but that primary malignancy has been metastated to any other site. In this scenario, you will code the principal diagnosis as secondary malignant neoplasm. The secondary neoplasm is still there in the body. The primary site malignant neoplasm has been eradicated, but the secondary malignant site is still there. It is not completely eradicated. So, you will code principal diagnosis as secondary malignant neoplasm, which is still there in the body. The secondary diagnosis in this scenario, it will be personal history of malignant neoplasm, which is Z85 series. So, to show that patient had a primary malignancy that is eradicated, and now the active malignancy in the body is not the primary. And also, you should not be confused. There are like a pro tip here is, sometimes what you will think, the patient's primary malignancy has been completely eradicated and there is no evidence moving forward of the primary malignancy in the body. So, you will have the urge to code the secondary malignancy as a primary malignancy. No, it is still the secondary malignancy. Primary malignancy will be the first malignancy that has occurred in the patient's body. Even if it's been eradicated, still that stays as a primary only. So, don't change the secondary malignant neoplasm to a primary malignant neoplasm. Hope you got my point. So, the next one in the chapter 2, neoplasm, E, admissions, encounters involving chemotherapy, immunotherapy and radiation therapy. So, all the admissions encounters involving these therapies. The first one, episode of care, involves surgical removal of neoplasm. So, the patient comes in, or admissions or encounters for the care involving the surgical removal of neoplasm. So, the principal diagnosis will be neoplasm only, because the patient has the neoplasm still. The second one under this admission encounters involving chemotherapy, immunotherapy and radiation therapy is patient admission or encounter solely for administration of chemotherapy, immunotherapy and radiation therapy. So, the patient is coming for these therapy only. We already saw this, I believe. So, the principal diagnosis will be the therapy, Z51 series, and followed by the secondary diagnosis, which is the neoplasm. So, Z51.0, it means encounter for anti-neoplastic radiation therapy, Z51.11 for anti-neoplastic chemotherapy encounter, Z51.12 for encounter for anti-neoplastic immunotherapy. You will code these followed by the neoplasm. The next one under this is third one, patient admitted for radiation therapy, chemotherapy or immunotherapy and develops a complication. Because of this therapy, the patient has developed a complication and the patient is admitted to treat that complication. So, in this scenario, you will code the principal diagnosis as Z51 series, Z51.0 or Z51.11 or 12, followed by the neoplasm and then by the complication. The next one, F, admissions or encounter to determine extent of malignancy or for a procedure such as paracentesis or thoracentesis. So, the patient's admission or the encounter is to determine the extent of malignancy. Extent of malignancy means how far the malignancy has gone, like how far the malignancy has spread. So, the principal diagnosis will be the neoplasm. So, even in this scenario, if the patient is having a chemotherapy or radiation therapy administered, you will not code that one. You will code the principal diagnosis as neoplasm only, because the reason for the visit is to determine the extent of malignancy, not for the chemotherapy or radiotherapy. The chemotherapy or radiotherapy has been administered later in the procedure, in the process, but it is not the reason for the patient's admission. So, you will not code chemotherapy or radiation therapy, you will code the malignancy only. So, the next one under neoplasm, G, symptoms, signs and abnormal findings listed in chapter 18 associated with neoplasm. So, what is chapter 18? It states the symptoms, signs and abnormal clinical and laboratory findings not elsewhere classified, that is the R series, R002, R99. All the symptoms, all signs and abnormal clinical and lab findings will be listed under that R series. So, if these are associated with neoplasm, you will code neoplasm as a principal diagnosis, and you should not code the signs, symptoms and all these ill-defined conditions from the R00 to R99 series as a principal diagnosis, because these are associated with the neoplasm. So, principal will always be the neoplasm in this scenario. So, the next one under neoplasm is H, which is admission or encounter for pain control or management. If the patient has been admitted or encounters or visits the facility to control the pain, for the management of the pain because of the neoplasm, in this scenario the reason for visit is the pain, right. So, principal diagnosis will be G89.3, which is the neoplasm related pain, acute, chronic. So, if the admission or encounter is for the neoplasm, then the principal diagnosis will be the neoplasm. So, the next one under the neoplasm is I, malignancy in 2 or more non-contagious sites. Like the same organ sometimes will have more than one malignant tumor, will have multiple of malignant tumor in the same organ, more than one. In this scenario, you do not know which is primary or secondary, it is not clearly indicated in the document. Then you will query the provider, ask the doctor or ask the physician, like which one you should consider as the primary site, because the same organ there are multiple tumor, right. So, you will be querying the physician or the provider. So, the next scenario is J, disseminated malignant neoplasm unspecified. So, what is disseminated? It means the patient has advanced metastatic disease, like the patient's metastasis has been advanced into various organs or various parts of the tissues or body. So, there is no known primary or secondary sites. They cannot differentiate the primary or secondary site. They cannot, analyze or give the clarity of which is the primary site or the secondary site. In this scenario, you will code this disseminated malignant neoplasm unspecified, which is C80.0. Next scenario here is the K, malignant neoplasm without specification of site. So, there is malignant neoplasm, but there is the site cannot be specified. So, first if you see anything like that, you should query the physician first. Even if there is no determination can be made about the primary site of the malignancy, it should be coded as C80.1, which is malignant neoplasm primary unspecified. It is equal to cancer unspecified. So, it is the patient has a cancer, but it is an unspecified cancer or unspecified neoplasm. So, it means it can be used only when there is no determination that can be made as a primary site of malignancy, and also it should be rarely used in the inpatient setting. So, the next one here is is it an I or J? K, L, is it an L? So, the next one is L. It looks like number 1, but it is L. Sequencing of neoplasm codes. So, how do you sequence the neoplasm codes? So, the principal diagnosis should always be the reason for encounter or where the treatment has been directed to. There is one exception though, that is, yes, you are right, anemia due to neoplasm. So, the first one under the sequencing of neoplasm codes, encounter for treatment of primary malignancy. principal diagnosis. So the primary site is to be sequenced first, followed by any other metastatic sites, because the treatment is for the primary malignancy. So the next one is treatment encounter for treatment of secondary malignancy. So in this scenario, the principal diagnosis will be the metastated site, which is a secondary malignancy, will be designated as the principal diagnosis. Then the primary malignancy should be coded as the secondary diagnosis. The next one under the sequencing of neoplasm codes, third one is malignant neoplasm in a pregnant patient. So pregnancy, when I say pregnancy, you should know that one, because we already seen the previous videos. This precedes, the O codes precedes all the other codes, right, the pregnancy codes. So O9A.1, this series, which is the malignant neoplasm complicating pregnancy, childbirth and puerperium, should be coded first, followed by the neoplasm as a secondary diagnosis. The fourth one under sequencing of neoplasm codes, encounter for complication associated with a neoplasm. So if the patient has a complication because of this neoplasm, so in the principal diagnosis will be the complication, the secondary neoplasm will be the neoplasm. So sorry, I said secondary neoplasm, right? No, the secondary diagnosis will be the neoplasm. The exception, as I already told, anemia associated with malignancy has a different exception. In that scenario, you will code, tell me the answer. Yes, neoplasm will be the principal diagnosis, the secondary will be, you're right, anemia associated with the malignancy. The next one under sequencing of neoplasm codes, fifth one, complications from surgical procedure for treatment of a neoplasm. So complication from surgical procedure for treatment of neoplasm. So the principal diagnosis will be the complication. Now you all know the drill, right, how the coding of diagnosis goes. So you should follow the same pattern throughout the coding books. There are some exceptions which I already told you, the neoplasm, the O codes, the pediatric code, like that. So you should always look into all those keynotes, then coding is very easy actually. These are just small hints, small tips you should get yourself, braced up, so you will not do the wrong coding. So the principal diagnosis will be the complication, followed by the current malignancy or personal history, because this is a surgical procedure. So if it's completely eradicated, then it becomes a personal history. If it is partially eradicated and it's not completely eradicated, it becomes a current malignancy. You remember that one, right? The personal history scenario that we saw quite a time back. The same thing applies here. The next one here is the sixth one under sequencing of neoplasm codes, pathological fracture due to a neoplasm. So in this scenario, you will code the principal diagnosis as M84.5, which is the pathological fracture in neoplastic disease. So what is pathological fracture? If you know the answer, put it in the comment section below. Let's see. The next one here is M, current malignancy versus personal history of malignancy. So the primary malignancy code should be used until the treatment is completed. So we already saw that one in the same chapter, right? The primary malignancy should be always primary malignancy till the treatment is completed and the malignancy has been completely eradicated. So till then you should code the primary malignancy. So if no further treatment for the malignancy is directed to that site and no evidence of any existing primary malignancy at that site, then you will go for the Z85, which is the personal history of malignant neoplasm, which we already saw, and they are just putting it again here as a new point just to confuse. Otherwise it's the same. The next one is the N, leukemia, multiple myeloma and malignant plasma cell neoplasms in remission versus personal history. So what is remission? So remission means that the signs and symptoms of that cancer has reduced, and remissions can be partial or complete, like sometimes it can be a complete remission for some period of time or some more years. So that is called as remission. So the categories for leukemia and category is C90, multiple myeloma and malignant plasma cell neoplasms have codes indicating whether or not the leukemia has achieved remissions. So in these scenarios, there will be, like for example, if you see the code Z85.6, it means the patient has personal history of leukemia. It means it has been completely eradicated. It becomes a personal history. The patient does not have a leukemia because of the neoplasm. It has been a history. So Z85.6. The Z85.79, which is the personal history of other malignant neoplasm of lymphoid, hematopoietic and related tissues. The next one under the neoplasm series. O. Aftercare following surgery for neoplasm. P. Follow-up care for completed treatment of malignancy. Q. Prophylactic organ removal for prevention of malignancy. These all have been discussed in the different section of the chapter specific guideline in the 21, which is the factors influencing health status and contact with health services, that is the Z codes. So, you will be coding these codes, which is the aftercare following surgery for neoplasm, the follow-ups and the prophylactic organ removal for prevention of malignancy. So, these sections are the C21, factors influencing health status and contact with health services, will be coding under those list of diagnosis. The next one here is the R, malignant neoplasm associated with transplanted organ. So, for example, the patient has a transplanted organ and there is a malignant neoplasm that has metastated or that has occurred in the transplanted organ. So, in this scenario, the principal diagnosis will be T86, complications of transplanted organs and tissue. Secondary diagnosis will be C80.2, which is a malignant neoplasm associated with transplanted organ. Then you will code the specific malignancy. The next one here is the S, breast implant associated anaplastic large cell lymphoma. So, if the breast implant associated anaplastic large cell lymphoma, which is the BIA-ALCL, is a type of lymphoma that can develop around breast implants. So, the patient has a breast implant and then around that there is a lymphoma that has developed. So, it is called as BIA-ALCL. In this scenario, we will code C84.7A, anaplastic large cell lymphoma, ALK negative breast. So, this will be the diagnosis. In 2023, this T has been introduced. This is a new narrative. This paragraph has been introduced. It's not there till 2022. So, this T is secondary malignant neoplasm of lymphoid tissue. So, when a malignant neoplasm of a lymphoid tissue is metastasizing beyond the lymph nodes, like if the malignant neoplasm of the lymphoid tissue is beyond the lymph nodes, is getting metastasized. In this scenario, you will be coding C81 to C85. The series with the final character of 9, which states that extranodal and solid organ sites. Instead of coding a secondary neoplasm of the affected solid organ, you should not code as a secondary neoplasm of the solid organ if that lymph node has been metastated to other lymph nodes. Instead, you should be coding this one as extranodal and solid organ. For example, if the metastasis of a B cell lymphoma is like metastasis to the lung, brain, left adrenal gland, then you will assign code C83.39, which is diffuse large cell, large B cell lymphoma, extranodal and solid organ sites. Instead of going for the secondary neoplasm of the lung, brain and left adrenal gland, you should code the C83.39, which mentions the secondary malignant neoplasm of the lymphoid tissue to differentiate and to identify. This new guideline has been started. I hope you all understood the neoplasm guidelines. It might seem sometimes vague and sometimes confusing, but just understand the guidelines. Just understand the guidelines and go by the rule. So, hope this chapter 2 neoplasm is clear to you. If you have any doubt, please feel free to put it in the comment section below. I'm as always happy to answer all your queries. If you find this video to be useful, please hit the like button. That will really mean a lot to me. If you're new to this channel, please subscribe and hit the notification icon so you'll not miss any of my future videos. And also please go and watch all my previous videos. This is Surya Johnson, your medical coding guide.